Good morning, good afternoon, and good evening, depending on where you're joining from. My name is Sireesha Bobbili. I am a portfolio manager in the Global Mental Health Program at Grand Challenges Canada, and I have the wonderful pleasure of chairing today's session, Systems Matter: Why Systems Thinking is Essential for Bridging the Mental Health Implementation Gap. So I can see that people are joining now. I'd love to welcome all of you and would love for you to introduce yourselves in the chat. Please tell us where you're from and what your interest in systems thinking is. As well, I'd like to encourage all of you to use the chat to ask questions throughout the session. Now, before we begin, I'd like to give a big thanks to the International Alliance of Mental Health Research Funders for convening this symposium. IAMHRF's role is to bring mental health research funders together around common challenges and opportunities, including helping to stimulate wider discussions like today's. I'd like to highlight that this session has been inspired by the Lancet Psychiatry Commission on transforming mental health implementation research and ongoing discussions about bridging the mental health research implementation gap. Please note that this is the first session in a series, so you'll be hearing about upcoming sessions that may be of interest. Now, before we get started, I'd like to outline how the session will proceed. I'll start with brief introductions of the speakers and panelists, who will then provide short presentations. A question and answer period will follow, and we'll end with a discussion with the Lancet Psychiatry co-commissioners. So with that, let's begin with the introductions. And in the order that we'll be hearing from them, I'd like to welcome Dr. Dan Chisholm, a social scientist with interests and expertise in public health, mental health economics, and health systems research, who works as a mental health specialist at the WHO. Dr. Deb Kyoto is the Director of Data Management and Evaluation for Youth Wellness Hub's Ontario Provincial Office and works collaboratively with the YWHO networks and system leaders across sectors to lead evaluation and measurement-based care. Her focus is improving service access for youth and the implementation of youth mental health interventions. Our third speaker, Rosemary Gathara, is a specialist in community health delivery, especially in mental health and epilepsy, who now leads Basic Needs, Basic Rights Kenya. We also have Dr. Bibi Oladeji, who is an associate professor at the University of Ibadan and a consultant psychiatrist to the University College Hospital in Ibadan, Nigeria. She is a co-director of the WHO Collaborating Center for Research and Training in Mental Health Neurosciences, and she's led training and capacity building efforts for mental health care and research. We'll also be speaking with Dr. Matthew Eisenberg, a health economist and associate professor of health policy and management at the Johns Hopkins Bloomberg School of Public Health, and Dr. Beth McGinty, Livingston Ferran Professor of Public Health and Chief of the Division of Health Policy and Economics at Weill Cornell Medical College, for their reflections as co-commissioners of the Lancet Psychiatry Commission on transforming mental health implementation research. Now, before we get to our speakers, I'd like to provide context as to why Grand Challenges Canada is chairing this session, as well as our interest in systems thinking. So if we can take a second to go to those slides, that would be great. Great. So I'm really excited to be here facilitating this important discussion about systems and systems change. As a portfolio manager at Grand Challenges Canada working in global mental health, we have a vested interest in systems change. To set the scene for our discussion today, I'd like to share with all of you how we're approaching systems change through our new Being Initiative. The Being Initiative's overall vision is to support the well-being of young people in a way that allows them to grow and thrive in their own contexts. We use a complexity science lens to understand that youth mental health innovations exist in complicated systems, composed of various actors, structures, relationships, policies, and social norms. And we understand that the traditional linear approach to research and implementation does not bode well in real-life contexts. So we've developed a unique coordinated ecosystem approach for the Being Initiative because we understand most people who could benefit from evidence-based mental health interventions don't actually receive them. So we seek to narrow the implementation gap by improving the availability of effective mental health interventions by supporting their widespread implementation in real-world settings. Next slide, please. Being's coordinated ecosystem approach essentially brings together diverse activities in a way so they work synergistically to support young people's mental health and well-being throughout the course of the Being Initiative and beyond. Next slide, please. Being's approach aligns with the Lancet Psychiatry Commission's third part of their Transforming Mental Health Implementation research article, which focuses on using a complexity science lens to narrow the implementation gap. For instance, a commission recommendation is to create research networks that facilitate interdependencies and learning. Now, since research is typically conducted by siloed teams and funded on a project-by-project basis, interventions, implementation, and dissemination strategies are developed in parallel, and there's little collaboration or cross-learnings. This is why Being is funding 3 different research streams in the same context. We want to focus on understanding potential facilitators and supports for youth mental health innovations, as well as the next steps for scaling and creating enabling environments within a national context. So we have proof of concept funding that tests new ideas in real world settings. We have transition to scale opportunities that nurture promising solutions so they're able to sustain and scale over time. And we also have a newer funding opportunity, which are ecosystem catalyst grants that support national and subnational activities that foster an enabling environment to help initiatives thrive and scale within complex systems. A key component of this is to convene and promote collaboration among diverse stakeholders to encourage them to support a shared agenda for mental health within both research and implementation spheres, and to encourage cross-learning across disciplines and sectors, and to break down siloed implementation. Having all 3 research streams in the same context allows a team to learn from each other and establish a well-connected network that supports effective knowledge translation of evidence generated for emergent solutions towards strategies for scale. Next slide, please. A second commission recommendation is to study bottom-up interventions and dissemination and implementation strategies. Quite frequently, interventions and strategies can be developed and carried out through top-down approaches. So for example, when they're developed by researchers or decision makers, and these ultimately may not be a good fit. Being prioritizes a localized agenda. So we believe that those closest to the challenge can better identify needs and barriers and offer impactful and sustainable solutions. So we worked with local stakeholders, including youth, to understand and determine critical drivers that negatively impact youth mental health and well-being to establish priority areas for investment in each of our 12 priority countries. Researching bottom-up interventions is the core of what GCC does. Within Being, we prioritize funding youth-led innovations or innovators to develop and test novel solutions to complex mental health challenges in their local context. And we believe that the knowledge and the expertise of these grassroots implementers is the best way to test and identify effective approaches. These organizations have firsthand knowledge of the complex problems that they're confronted with, and are therefore best placed to identify and test bottom-up solutions and processes that will likely work. Finally, targeted financial and non-financial support is provided to innovators to strengthen the pipeline of tested mental health innovations that target young people. And this involves building research capacity through Origin, who is our learning support provider. Next slide, please. Other commission recommendations that Being aligns with are centering equity. So our most important partnerships are those with young people as well as those with lived experience of mental health challenges. They advise on our portfolio, our programs, and lead funded initiatives and offer valuable insights. Another commission recommendation that Being aligns with is structured funding opportunities to prioritize an integrated model. So we invest in partnerships and a mental health portfolio rather than discrete projects. We recognize that it takes more than funding single interventions in isolation. So our coordinated approach allows a focus on the complex environment. that influences how organizations operate. So things like government policies, social norms, market dynamics, and more. We understand that those create challenges for organizations to implement solutions. So we develop enabling environments for mental health innovations to scale and sustain over time. And this includes fostering connections and collaborations, strengthening networks, and focusing on transforming the narrative that underpins how youth mental health is understood and prioritized. So with that, if we can go to the next slide, if you'd like to learn more about being or find out more about our current funding call, a link has been dropped in the chat. Now that you've heard a bit about being and how we use a system approach to address the implementation gap, we'll move on to the main attraction. But before hearing from our speakers, we'll be hearing from Professor Jeffrey Braithwaite, a leading health services and systems researcher with an international reputation for his work, investigating and contributing to systems improvement. Jeffrey is based in Australia, so can't be here with us today, but he's kindly sent a video giving us his views on how systems thinking can support implementation. If you have any questions, please place those in the chat, and Beth McKinsey will kindly answer them. And if there's anything we don't get to today, Jeffrey has kindly suggested that he will answer the questions by email later on.
Good morning, good afternoon, good evening. I'm Professor Jeffrey Braithwaite, Professor of Health Systems Research at the Australian Institute of Health Innovation at Macquarie University. I'm also a Lancet Commissioner on scaling up mental health implementation research. This is an online symposium on systems matter, run jointly by the Lancet Psychiatry and Grand Challenges Canada. Welcome to my bit, which is helping to frame the symposium. So how can systems thinking support mental health implementation? And my specific theme is, don't forget about complexity. Health systems and mental health systems are extremely complex. No one has invented more complex systems than those that are delivering care to patients and clients. I'm from the Australian Institute of Health Innovation, and we're a group of about 300 researchers in Sydney, Australia, examining health systems and with research trying to improve it. We have 7 research centres. The centres in the middle, headed up by people with pictures, are those that are university centres at Macquarie University, and the others come and go as we get large research grants. But what you see in the titles is what you get on the tin. We do research on safety, with big data. Data and AI. We do research on aged care, mental health, acute care. Wherever we see care systems, we strive to get research into practice. We're working in 152 countries at last count. So I'm specifically focusing on complexity because a lot of our work looks at the health system and the mental health system and looks at the complex dynamics of the system. And I'm also interested in what we do with our research, which is to try and provide evidence to rethink current approaches. And here's a wave from us, some of us in our institute in Sydney, Australia, to you, wherever you might be. So let's start. First things first, what are systems and what should we target if we're living in or being a policymaker or a clinician or a client operating in a complex adaptive system? What should we target? Well, let me give you some baseline data. So it takes about 17 years for only 14% of evidence ever to enter practice. And there's 36.5 million papers in PubMed. So there's a lot of research around. But how do we put it into context and then into practice, given those headline numbers? About 60% of care, whether it's mental health care or acute care, about 60% of care is in line with level 1 evidence or consensus-based guidelines. 30% of healthcare is waste, and about 10% is harm. And those 60-30-10 numbers have remained fairly static for several decades. It's not to say healthcare isn't doing well and improving, because we can do much more in mental health and in acute settings and aged care than we ever could when I was younger. However, although medicine is improving and offering more services and more services to complex patients and clients, these numbers, these headline numbers, have remained relatively static. And for me as a researcher, that's the scale and scope of the problem. Many people have suggested solutions to that, and largely they look like a pipeline. So most solutions look like, let's do more research across a pipeline. But the problem with pipelines is they fracture. The evidence doesn't get to the next stage. We don't do the study, or the study is locked up in PubMed amongst those 36.5 million papers and doesn't get into practice. So many people have said this is failure. The research and evidence-based enterprise doesn't deliver what we need it to deliver. So that brings us to the nature of the system that we're trying to improve. It's a complex adaptive system, and linear models are just that. They kind of simplify reality. So complexity, there's lots of characteristics of a complex system, fuzzy boundaries, interacting agents that interact and sometimes don't, and are sometimes in silos, sometimes co-evolve and sometimes don't. And complexity is a feature, especially of healthcare and mental health care. Many models, this is an illustration of, well, what about the dimensions of complexity and how can we categorize things from simple to complex? But the reality is healthcare and mental health care tends to look like this rather than something more simple. It's not really well described and well understood by linear descriptions, linear depictions. If you want some resources, we've written a paper. It's not specifically targeted for mental health care, but we've written a paper, Complexity Science in Healthcare, a white paper a couple of years ago. It's on our website, in our institute, at our institute website, and it's a free download. What does it say? Well, there are populations of people interacting dynamically, and they have emergent rules. And sure, they have top-down rules. People try and constrain or enable complex systems, but they have emergent rules and governance mechanisms, and they also are comprised of a whole lot of bottom-up networks trying to deliver care. So that's a bit about complexity. What about interacting subsystems in this complex dynamic mental health or acute or aged care or rehabilitation system that I'm describing? So here's a couple of studies we've done just to illustrate. We do a lot of work looking at healthcare as a bunch of social networks, interacting, nested subsystems. So here's a study in cancer that might be illustrative. So we start off in 2012. There's a network of people like me, oncology researchers, trying to get more evidence into practice in cancer care in Eastern Sydney, Australia, not Sydney, Canada. So there's a bunch of people that don't. So people and the lines between them are connections. So that's what it looks like as we go through the years. This is longitudinal research. We did this for more than 10 years. And you can see the network we're gathering gets more dense. There's more intense relationships. There's more people interacting to try and provide better care to oncology patients across time. And so here's another one where we looked at, I'm a member of Australian Genomics, trying to harness what we're learning from genome projects into, from a research project into practice. That's the network. In 2016, before 2016, a whole bunch of people like me and geneticists and genetic counselors and researchers and policymakers and patient groups all getting together, the dots of people again, all getting together to say, how can we get genomics into practice? That's what the network looked like by 2018, a couple of years later. And this is ongoing work. So this tends to describe the nature of the complex system, delivery system, and the nature of the interactions between the parties to the system. Here's another one we did in mental health. This is Lifespan, an Australian suicide prevention initiative. And here are the existing ties between people, the new ties, and the lifespan ties as we go across time. You can see the value of this work instantly. It's a depiction of the extent to which people are interacting to provide better care, to improve take-up and scaling of evidence into practice. We can't forget also the social determinants of mental health. We know a lot about this. Here's a paper where we're working on this with my colleagues, Louise Ellis and Kate Chiruka, two senior researchers in our research institute, where we're looking at mental health conceptualized not as a linear, how do we get policy or evidence into practice, but how do we do that in the context of a complex system? You can read this paper at your leisure. I've just provided some bullet points of what we did and this complex intervention. So what we're doing is providing a brief case study, which I won't speak to too much, but I'll leave the slides with you about this sort of project. I'm sure there are many other projects you're going to hear about during the symposium in more detail. So this is the lifespan sites where people are trying to provide care, mental health services, but with a complexity focus. And then we looked at the complex dynamics by interviewing people, running focus groups, trying to understand how care was actually delivered, rather than thinking, how do we think care might be delivered? We think this is very important. And here's a couple of representative quotes of the different communities and the different contexts that deliver care to patients. There is not much standardization in a complex adaptive system when you think that each context, each subculture differs from the next one in a different site delivering care. And that's both the benefits of a complex system, but it's also, so for some people, a bit infuriating that each context differs from other contexts. Here's some more data from this, and I'll just leave these slides with you with some representative quotes. So you can see the texture and the tenor of us trying to get to the different contexts within which care is being delivered, the different subcultures. So what does this all mean for mental health? Well, here we go. We use a lot of harnessing implementation science tools, like the theoretical domains framework and the consolidated framework for implementation research, which many people in this symposium will talk about later, and many of you are familiar with, to try and understand that different contextual, those different contextual factors which help to understand the nature of the complex dynamics delivering care. So let's discuss this. A couple of points I'd like to finish with, and others are going to take on this baton from me and talk in more detail. One is RCTs are necessary, but they're insufficient in the view of the Lancet Commission, because they kind of hold a control group and control it, do an intervention, see what difference there is, but it's a controlled environment. It often doesn't reflect the complexity and the dynamics and the contextual differences in the different settings that mental health flourishes in and provides care in. So we need to look at how interventions contribute to reshaping a system in favorable ways. And we need research designs that foreground the dynamic interactions and emergence. So we in the Lancet Commission often argued that we need to favour mixed method studies running alongside maybe a well-designed RCT to understand these complex dynamics, to understand the system within which care is being delivered. So, formative evaluation of the delivery of mental health services is very important. Context is important. The subcultures delivering care is important. And striking a balance between the rigor of, say, an RCT with the rigor of a mixed method study running alongside each other becomes, in our opinion, very important. You can use PDSA cycles then, plan, do, study, act cycles to continuously improve care rather than an RCT at a point in time and then leaving that alone and saying, right, this evidence is universal and is longitudinal and it's going to last forever. Because in a complex dynamic system, it's not universal and evidence is not last forever. So embedded research is another angle. We do a lot of that. Instead of researchers staying in their ivory tower, going out and working alongside policymakers, clinicians, patients groups to really get that real world knowledge and then sharing it across the mental health system and across countries is the kind of research we favour in my research institute, and one of the arguments that we put in the Lancet Commission. So finally, I just point out that there are models for learning health systems, which are another way of looking at how do you get more evidence into practice and harness all the data that's being produced that sometimes doesn't get used. So the classic Institute of Medicine, now the National Academies in the US, said there were four dimensions of a learning health system: harnessing the science in informatics, developing partnerships with patients and clinicians, providing incentives for people to use data and get evidence and take it up into practice, and having a continuous learning culture. And we did some work a couple of years ago and said, we also need structure and governance around all of this data. It's not just going to assemble itself into formats that people can use. And so we favoured this fifth dimension as well. And we put it into a study, and it's called it the IOM Zirinsky-Braithwaite model. You can look that up. And we thought if you put the quadruple aim and the 5 dimensions, maybe that's a good framework for harnessing all the data that exists in mental health and trying to work with clinicians, policymakers, leaders and managers in a fruitful set of partnerships to get more take-up of evidence and better implementation science. So now that we know this, my argument and the Commission's argument is, can we do a shift from linear thinking, where many of us in the old world were thinking if we do X, we will get Y, to factor in the complex dynamics of the system. So we're moving from this kind of model to one where dissemination and implementation research and real world implementation is better understood and factored into our work. So relating this to the Lancet Commission, in the Lancet Commission, we had 5 sections in our report. It's a very long report. I commend it to you, but a summary is replace the research to implementation pathway with a more integrated approach. Embed equity into mental health intervention and implementation research. We want equitable distribution of mental health services. Approach the implementation gap with a complexity science lens, which is what I've been talking about. Expand the use of non-experimental approaches to establish causality, and use a transdisciplinary approach to generate actionable knowledge to close that well-known gap between what we know and what we do. So I can't take questions because I'm not there, but I'm sure the organisers are generating an opportunity for questions, comments, observations. I'm available later. You can email me if you wish. Here's some of the teams in my institute that I draw from and draw inspiration from. Here's some recent books that we've published on various aspects of care that are relevant to all sorts of care, including mental health care. Here's some books I'm working on at the moment, so stay tuned. And here's how to get hold of me. And these are on the end of the slides, which I'm very happy to share. And the organisers will share a PDF copy of the slides at your request. So thank you very much. I hope I've helped contribute to framing, providing a framework for the work that follows in this symposium. I'm tendering my apologies that I can't be there for the duration of the symposium, so I'm putting down this recording. Thank you very much. Enjoy the rest of the symposium.
Thank you to Professor Braithwaite for providing a foundation for all of us by defining systems and complex systems, as well as the need to move away from linear research processes and linear thinking to more complexity thinking. I'd like to move on to our second speaker, who is Dr. Dan Chisholm, who will be sharing lessons learned from the Emerald Consortium, a multi-site mental health systems strengthening program. I'll hand it over to you, Dan.
Thank you very much, Sireesha. So I'm still absorbing some of the content from that previous very helpful foundational presentation by Professor Braithwaite. So I think my presentation now can usefully complement that because it focuses in on a specific mental health system strengthening project that was undertaken a few years ago now in half a dozen low and middle income countries. So taking some of those foundations and applying them to the countries and health systems of several countries in Africa and Asia. So that's what I'll speak to. Next slide, please. So the first question I need to address is what was this Emerald project, and perhaps more interestingly, why was it proposed and funded and undertaken? What was the thinking behind it? What did we look into and in which localities? I'll spend just a moment or two on some illustrative findings from the 5-year work program, just to give you a sense of the kind of health system questions and research issues that we addressed, and then what can we take from it? And again, as I say, complementing what's already been said. So let's start with number one. Next slide, please. So I've started here with a kind of orientation around what are we talking about. This is one of several iterations of a health systems framework. First one I became familiar with was from the World Health Report back in the year 2000 when I actually joined WHO. There've been several revisions of that health system framework since. This is one probably dating to around 10 or 15 years ago, and was the one that was prevailing at the time that we prepared this proposal called Emerald. So the reason for showing it is that really this was the inspiration for the project, was to take this very schematic overview of what a health system is there for, what are its functions and components, what are some of those intermediate kind of outputs like coverage or quality of care, and what are the final goals and outcomes that should be at the heart of every health system. So effectively, we took this and thought, well, how can we map that onto some to mental health services and systems? What are the kind of policy questions that might arise when you look at some of these system building blocks? So that if we can go to the next one, please, Mona. That as I say was the kind of inspiration. And so this project came about, funded by the European Commission over 5 years to the tune of around 6 million euros. It was undertaken between 2012 and 2017, involved 6 main countries as well as several partners, including King's College London. The PI of this project was Professor Sir Graham Thornycroft. There were others in Europe like TPO in Amsterdam, the Autonomous University of Madrid in Spain, and ourselves at the WHO based in Geneva. So an important part of this is that we kind of overlaid this, that we sort of developed this mental health system strengthening project. We kind of overlaid it on an existing, also large mental health services research project called the PRIME study that some of you may have come across in your readings. And that was being undertaken in 5 of the 6 countries. Nigeria was the odd one out. That joined the Emerald project, but was not part of the PRIME project. And that was interesting in its own right, because we kind of needed to sort of separate out the levels, the questions that we wanted to resolve and look at from the health services research perspective versus the higher level of sort of more health systems and health policy research questions undertaken through the Emerald project. So the overall aims were to essentially try and look at some of the most significant barriers to mental health system and service development, and look through those and try and identify solutions for how to overcome those barriers. And as I mentioned, we did that through reference to the WHO Health System Strengthening Framework. So we can go to the next slide, please. These on the left were the 3 main kind of health system topics or areas that we investigated. So the first one was, if you like, and it's sort of shown schematically on the right, the one which is sort of highlighted in green there, Work Package 3. That was around the kind of health system inputs and looking at issues around adequate, fair and sustainable financing and resourcing. Another package looked at the kind of process of care, particularly the integration of mental health within health services and what that implies for the effective delivery of services and the governance of those services at the clinical level. And then a third area looked at more, we could call the outputs, this focus on coverage and goal attainment, the health system goal attainment I was showing a bit earlier. And then, of course, the overall kind of evaluation of that. So this kind of dynamic, typical kind of systems approach to the design and execution of this program of work. If I can go to the next one, please. This is an example for the work package looking at resourcing and financing, just to give you a flavor of the kind of health system questions that we sought to address. So on the adequacy front, what are in fact the human, the financial, other informational resources that are required to appropriately scale up services and reduce the treatment gap. Another one, what are the implications of this scale up on the existing health system? On the fairness or equity side, so what is the distribution right now in terms of the mental health resources? Are they equally or unequally distributed? Who's paying for services? Who's not paying for services? What are the financial protection mechanisms that are in place for people who are affected by mental health problems? And what are the welfare or economic consequences of mental ill health at a household level? And what extent do economic outcomes, for example, income generation, employment, What happens to that as people have access to services? And then a final area was around sustainability. What are the policy options across countries for paying for service in a way that is feasible, fair, appropriate, but also sustainable over the longer term? So these are all, very, practical, relevant policy questions, real policy questions, which we sought to address. Next slide, please. So here are just some very kind of high-level examples of some of the outputs or findings that we obtained over the course of this work. So, for example, we to address that question of the impact of mental ill health on households, that actually requires and did require a household survey. So we mounted a survey, identified households actually through the PRIME study. And then we went back to households of those individuals who were coming into contact with care, and interviewed household members about the impacts of mental on their ability to on their spending, on their income, and different dimensions of household welfare. To look at the resource needs, so we generated a tool and some projections on that. For the information, we actually identified and then tested a series of indicators for use in routine health information systems. And through that, we made some contributions to new understanding about the effect of mental health conditions on households and the consequent need for financial protection. Some evidence-based strategies for how to improve health system governance, as well as that one I just mentioned about health information systems. So these are the different kinds of outputs to what you get from a clinical, or health services research project. And then the final slide, please. So what do we learn from this? Well, first and foremost, I think through the application of that sort of health system framework to our area of interest, mental health services, you come up with a different set of questions and issues for mental health policy and practice, particularly around the scale up. So interventions are available, but how are they really scaled up, and how do we do that in the context of the complexity that was just being referred to? Second point was, of course, that taking a systems approach immediately takes you into a very multi-dimensional, many different disciplinary perspectives and methods are needed, a kind of mixed method, qualitative, quantitative approaches needed to address some of those system questions. And finally, the need to establish at all levels, whether it's everyone from people with lived experience who are working with us to and service users and right through to policymakers, some kind of exposure and trying to establish that kind of systemic thinking and demonstrate the consequent or the needs of the health system needs around the scale up of interventions was a key kind of finding or lesson learned. So I'll stop there. Final slide just to say thank you. You can see more information about the program there in the link, and I'm happy to address any questions a bit later in the session. Back to you, Sireesha.
Thanks so much, Dan, for that wonderful description of the Emerald Consortium. There's a lot of great information that you've provided to us there. There were a few questions in the chat. I thought that perhaps we could look at one specifically. A question came up about your research and whether your research looked at access to services in urban and rural areas in the LMIC settings that you are working within. You're muted, Dan.
Thanks for the question. Well, for this particular program of work, as I mentioned, we kind of overlaid this on top of an existing program of research, which was very much around integration of mental health care into general healthcare service, particularly primary healthcare. And so most of the areas where we were doing the work were primary health, were districts, rural districts, with a network of primary healthcare services and facilities, and that's where the service development was taking place. So then you could say, as a result of that, the focus was de facto looking at rural more than urban situation. Of course, the situation in big conurbation cities, towns, is different in terms of the many system issues, not least the human resource one, because a lot of people prefer to be in cities rather than out in the districts in the rural areas. So I think there are separable questions to address when looking at cities versus or urban versus rural context. But for this one, it was mainly rural.
Thank you so much, Dan. I think we do have a few more questions that we'll try to get through to you in the question and answer period. But for now, just to stay on track, I'd like to move on to our next speaker. I'd like to invite Dr. Deb Kyoto to provide her presentation on the learning health system, how research is defined, embedded, and used, including meaningful engagement with end users. Deb, over to you.
Thank you so much. And it's an honor to be here amongst everybody and hearing all these incredible ideas that are happening on an international stage. So I'm going to try to integrate some of the things that we've heard this morning and some of these comments as we go through this learning health system that we are building at a pan-Canadian level here in Canada. Next slide, please. So today I'm going to talk to you a little bit about integrated youth service. It's a dynamic pan-Canadian and international movement led by our colleagues in Australia at Headspace, Jigsaw, and Ireland that aims to really build effective youth-focused integrated services for young people, typically between the ages of 12 and 25, for things that they may need support with respect to mental health, substance use, all of the related issues. Integrated youth services really focuses on bringing together existing service providers in a community to deliver services in a new way. It builds on international models, and really the purpose and I would say the vision of IYSs in Ontario, where we are right now, but also at a pan-Canadian level, is really to achieve better outcomes for young people. Typically in our traditional mental health system, as we heard earlier, there are lots of challenges. There's unwarranted variations in practice and services. We have a very difficult time getting evidence incorporated. There's probably modest performance despite the high system costs. And really, we don't use our clinical and administrative data in adequate health decision making and or quality improvement. And so integrated youth service is a model, but it's also defined by key sort of principles that can be implemented in many different kind of models and jurisdictions about how to support young people in the best possible way so that they can achieve their best outcomes. Next slide, please. So what you'll see here is that Youth Wellness Hubs Ontario is a network of networks. And so in the green circle, you'll have all of the different providers who typically provide care for young people, but traditionally in a very siloed way. What Integrated Youth Services does is bring all of the multidisciplinary collaboration across sectors together, typically in one space under one roof, and they provide that seamless care to young people. It reduces the transitions. There's a single entry friendly access point for service. It removes the barriers because now with, there's no artificial age restriction between child and youth mental health versus adult mental health. For a young person, they may not even know that it's a new multidisciplinary collaborated approach. What they see is that they don't actually have to tell their story multiple times. They don't have to navigate these like fragmented systems and silos that exist in communities. And they really can walk in and access service. So they don't have to wait. In Ontario, we're seeing wait lists of 6 months to 2 years for mental health service. This model really supports a walk-in where young people can access that immediate service that they may need. And The greatest thing about the model, I would say, across Canada is that it doesn't just support mental health and substance use and primary care needs, but also the early intervention health promotion needs that bring young people to the door. So while many young people come in, let's say for mental health support, they want help with their feelings, their emotions, their relationships, they often want to first come in to get to know people, to have a space that's their own, that's a safe space. They want to hang out, they want to get food, they may need a place to shower. And it's through those really low barrier early intervention health promotion type supports that they then will transition to higher intensity needs. And so it really builds that up for them. Next slide, please. I want to show you the leadership that's happening across Canada, and that cannot be possible without tremendous funding support, both provincially, federally, and philanthropically, to develop all of the different learning health systems across the country, really taking that step forward, moving beyond the traditional approach, but building a learning health system, which I'll tell you a little bit about how we take research, we take quality improvement, we take evaluation, and we really embed it within the learning community of our learning health system in a really rapid, evolving way, so that the evidence doesn't take, what did we hear, 17 years to get into practice, and only 14% of that does. And we really involve all of the people within the system to make that happen. So integrated youth services is transforming, you can go to the next slide, please, the system of care for young people, predominantly because the LHS is a fundamental strategy for enabling evidence into the system transformation. And so we heard this morning how important it is to build a pipeline, for example. LHS will allow you to do that. Next slide, please. So what is the learning health system? We've adopted the Alliance for Healthier Communities definition. It's really the next level of thinking of how we learn in organizations. So hospital systems have been implementing learning health systems for a very long time. The idea and concept hasn't really come out of nowhere. In the early 70s and 80s, we were really focused on how individuals and organizations learn, how we introduce change, how do we reflect on action, and how do we do that work at an individual level. The shift now is, how do organizations learn, and how do we learn that together in a collaborative way? So really quickly, a learning health system is one that's characterized by continuous learning and growth, and it brings together information from practice and research and feeds it back to teams in a way that's meaningful and usable to them. And that helps to improve care. So it's not just the research evidence, it's not just the quality improvement or the evaluation, it's also the everyday care experience that young people or patients or families might experience, and using that information to really inform the quality of care and how to improve the quality of care. Next slide, please. In Canada, many of us are using Dr. Munir's LHS model. It's called a framework for value creating learning health systems. And the reason why this model is really important for us, and you'll see that at the foundation, is really the core values. And what are your core values within your learning health system is really important, because that's what drives your system change. That's really the vision to support young people to achieve their best possible outcomes. It really takes into account the complexity of the ecosystem, because there are many dimensions to learning. You can have the practice can convert to data, the knowledge goes to practice, the data goes to knowledge. This is really the fundamental learning cycle, the PDSA that we heard earlier, with a bit of a different nuance to it. And with the learning health system outcomes, they really think about the patient, the provider, population healthcare, and population health and healthcare costs. So really, it's like you need all of these folks within your learning health system to provide evidence, to use that evidence, to enable that evidence, to really make that learning health system rapid, evolving, and improving the delivery of care for young people. And how we create value for all participants in the learning health system is quite complex. And that's something that we're always kind of trying to learn from our participants within the learning community. Next slide, please. So what does it take for a learning health system to achieve its vision? Next slide, please. There really are 5 building blocks, and I won't have time to really go through how we define each of these today. But really, you know, all of these depend upon people. Next slide, please. And I'll share a couple of components of them. But ideally, learning health systems are about the lived experience of those experiencing the care within the system. And ensuring that their voices are amplified is really what's going to make your learning health system relevant. It's going to make it meaningful, and it's going to make it use evidence in a way that can rapidly improve the delivery of care for young people. Now, the learning community, which is what I really want to talk about in the next slide. The learning community is really about how you bring all of those relevant partners together to tackle a major system problem together. So traditionally, we're researchers, we have a research interest, we have a question that we want answered, and we go about and we do that research. What makes learning health systems different is that you bring all of those partners on this screen together. This is our learning health community. Yours might look differently. And when we talked about governance, this is at the level of where that governance would sit. So you'd have a governance group, working group made up of all of these individuals from your learning community, so that together you can think about what's the major system problem we need to tackle so it's relevant and meaningful to them. How can we be involved in this learning and improvement process? How do we share information together and reflect critically on those problems? And then how do we evaluate those results and feed them back into that system? Next slide, please. Another really important part of the learning health system is data. Obviously, you need the technological infrastructure to make a learning health system work. You have to measure what matters. We often talk about what's feasible versus what's optimal. Currently, right now, like in community and schools, nobody will agree to an RCT, as you heard. Nobody even agrees to a waitlist control, because that's just not something that community or school-based, whenever you're evaluating a program, want to do. So you have to think about what measures will matter and what methodology will matter the most and is optimal. We have an integrated data platform across the province that collects information to share that information across the learning health system. We regularly report and we make that data transparent and meaningful back to the learning health system. You have to do that quickly. You have to have technology to have that regular reporting and making sure that it is responsive to their questions, and that all of your measures and all of your methodology are co-designed by your learning health system learning community. For us, that's really embedded within youth and family. Next slide. And then I know my time is almost up, so I'm just going to skip to the last one because I really want to share with you that you can skip ahead. Youth and family priorities. We've been doing a decade of work engaging young people who have accessed mental health services across the province, and they have told us that you need these things. You need to make sure that the data is accessible and usable. That means it's got to be in visualization. It's got to be in tools that make sense to us. It's got to be in multiple formats and multiple languages. Transparency and trust. Let us know exactly who's using that data, why they're using it, and where it's going to go. We want actionable insights and impact. Tell me what services work for me in my community. That's what they want. They want really meaningful, actionable insights. Collaboration and co-creation. They want to be involved in the development of the research questions. They want to be involved in how we ask those questions on surveys, in how they want those focus group questions, really collaborating with youth and families' voices as equal partners at the table. So operating as a learning health system, it's complex. Governance is really complex. There's lots in place within integrated youth services. What we're working on right now across the country is really operationalizing it. How do we define success, and making sure that the outcomes we collect matter to everyone, and ultimately that young people are achieving their best possible outcomes that they can. So thank you.
Much, Deb, for sharing very rich insights about the use of an integrated youth services model as a learning health system. So we have quite a few questions that have come through the chat. I'll try to get through as many as I can in the next couple of minutes. But our first question for you is, how different is a learning health system as compared to integrated knowledge translation or knowledge mobilization?
I mean, I'm sure others can answer this too. I would say what makes the learning health system different from the integrated knowledge translation is really the learning community. And so you have all of these partners, decision makers, researchers, policy makers who sit at the table to really help define what is important within that learning health system, what complex problems you want to solve, how you want to solve them, and how that information gets fed back into this continuous feedback loop. And so to me, it's much broader than the integrated knowledge translation pieces, because people are at the heart of that and the values are at the heart of that. So for example, one of the values that we have within Youth Wellness Hubs Ontario is that if we are applying for funding for a grant, all of those research ideas come from our learning community. We pull them together, we send emails, we have meetings, and we say, you tell us what questions you need answers so that you can deliver care in a more equitable, high quality way to young people. And even if those research questions are not something that we were necessarily thinking about, those are what drive the work that we do. So to me, that's a little bit how I see that differently. And then they're involved in actually disseminating and supporting the translation of that information and developing the knowledge products that are meaningful, because research papers are great, but very few people in the community want to read that. They want infographics, they want research briefs, and you need people to make those. So I think there's some similarities, but definitely differences.
Thanks so much, Deb. So I'm really hearing that you center people's voices, patients and families' voices in the entire process. So another question that has come up is regarding the differences between stakeholder landscapes in low and middle income countries compared to high income countries, such as variations in resource availability, community involvement, healthcare infrastructure, and policy-making processes. So how can learning health systems be tailored to support mental health integration in low and middle income countries?
I think, and this is a tough question, but I think in actuality, like the learning health system model is perfect to be able to work with different communities, whether it's low or high income, because it really prioritizes the context and it really thinks about the nuances that exist within the social context of people's lives. And so for us, it's really important that we think about urban versus rural communities, as well as those communities, Indigenous communities and Francophone communities in Ontario. And so by including those and engaging those partners and bringing those partners together and being very responsive to the community needs, learning health systems can support mental health integration in all of those different scenarios, because you're really thinking about the collaborative networks and the partnerships across all of your community partners to enhance all of the things that you might be doing with respect to your mental health approaches, the generalizability and adaptability within that particular context.
Much, Deb. I know a difficult question, but it's great to hear your perspective. I want to say thank you to you, Deb, and thank you to our first three speakers. We're going to take just a few minutes break just so we can stretch our legs, grab a coffee, and we'll return in a couple of minutes to a few more engaging presentations from our remaining two speakers, and that will be followed by a question and answer period. So we'll see you back in a couple of minutes. Hey, well, that was a very quick break, but thanks for returning. We'll now hear from Rosemary Gathara as she presents on responding to community needs using systems thinking. Rosemary, please take it away.
Yeah, thank you, Sireesha, and thank you everyone joining in. From Basic Needs, Basic Rights Kenya, a local community-based mental health organization that seeks to foster communities that value mental health using rights-based approaches. Next slide, please. So our organization embraces systems thinking, and this is because our approach is informed by a belief that addressing mental health and mental illness goes beyond health systems, because our communities do not experience mental well-being and illness as simply health issues. There are social and economic causes and effects. Our community interventions have components of clinical, economic, and social well-being of individuals, as well as the resilience of their communities. Talk a bit about why that is so in our country. So next slide, please. So in Kenya, we have a 10% from the Ministry of Health, we have a 10.3% prevalence of common mental disorders and a 75% treatment gap. Some of the reasons given for this high treatment gap is the low mental health literacy. There are late interventions and consequently severe mental illness. In fact, for a long time, mental health has been viewed as an issue for psychiatrists and psychiatric facilities, and there are very few and far between. We have about 100 for a population of 60 million, or I think recent statistics, 150 psychiatrists for a population of close to 50 to 60 million Kenyans. And there has been an audit on the provision of mental health care services in Kenya, which shows that there are huge gaps. And some of the gaps really show how these issues cut across different sectors. So for example, the Auditor General, when doing a performance audit, highlighted challenges to do with decriminalizing suicide and even other conditions such as alcohol and substance addictions, that people need care, not to be criminalized, and that's not a function of the health system. There's an issue of knowledge. There's very low mental health literacy. Again, he pointed out that this needs to be introduced early in life, and schools are a good place to do this kind of health education. And our Ministry of Health is now working with the Ministry of Education to develop school mental health guidelines. The Auditor General also pointed out a need to organize family and community-based mental health programs. Now we have a family division in our Ministry of Social Services. So again, there are different systems that interact when it comes to providing mental health care. And also, we also have poor prognosis and a high number of defaulters. Again, quite often this is an economic issue. People cannot afford the cost of care, whether it's a cost of transport to a health facility, or they don't anticipate the long time it will take for somebody to continue in care. So they do need some form of livelihood for themselves, for the caregiver, and for the person experiencing a mental health condition to sustain their care. And of course, there are the high levels of stigma. Next slide, please. So we implement the basic needs model for mental health. And this model, the basic needs model integrates several elements to form one model of care. And the underlying thing is to have community participation. So we first interact with the community where it will look different in different parts of Kenya. We implement this model in Kilifi with a different partner organization called Tinada in Kisumu, and we implement the same in Kilifi. These are very different parts of Kenya. And we recognize it will look different in the different areas we implement in. So we first talk to the community. What are their mental health needs and what are the resources? And the resources look very different. So for example, when we talk to women in Kilifi, And they'll say for them that opportunity when they can gather together in their women's group is very good for their mental health. They can share the challenges they face. And even they do small table banking sessions, and they can gather a bit of income to alleviate the economic challenges they face. We'll have the men say how important it is to them to attend the evening football match and just to gather with other men and talk and discuss how to cope with the challenges of day-to-day living. And even that kind of psychosocial support. So again, that's a sports thing, nothing to do with the Ministry of Health, but we have to insist that these spaces be availed to the community so that they can engage in these things that benefit their mental health. As the Lancet report highlighted, it's important to have equal partnerships with the communities and to have interventions tailored to their context. It's true for research and, of course, a principle in implementation to have co-creation. We also identify priority feasible actions. So when we talk community development, we'll discuss with the community what does that look like for them? What do we need to develop for them to have good mental health? What kind of psychosocial support structures exist, livelihood opportunities, and the mental health system currently in place? What gaps are there? And we'll have conversations with government leaders, local leaders, what funds are available, what other projects are ongoing in the area, so that we do not come with a standalone intervention. It needs to be integrated within the government systems. So then we do not limit ourselves to the Ministry of Health. We'll work with the Ministry of Social Services and other government departments when addressing the issue, and of course, other implementing partners in the area. Next slide, please. I'd like to briefly talk about one of our project participants, Amina. And for her, it would be very difficult if we only approach this with a health lens. There are she has many competing priorities, and she has really limited resources. As you can see, this was a photo taken when she was planting on her land. She has limited access to resources. She could do the planting, but the money goes to her husband. So she has to negotiate. If she needs to go to the clinic, she has to negotiate to get the money back. There's climate change issue, like you can see how dry the area is. So it's planting, hoping for rain. Again, we have to talk with government departments about mitigation when there are disaster mitigations if the crop fails. What do you do for her? What does the government have in place for social protection for her? There are huge gender issues. She's worried for her daughter, who will probably be married off young. Her many children end up in the same situation she's in now that challenge her mental well-being. And we do have school programs that address adolescent mental health. We have issues of low literacy. So sometimes organizations produce a lot of written material, doesn't benefit her because in Kenya, most people who can read and write in English and Swahili, not in their local language. So it's easier to do radio campaigns. Again, that's a media issue more than a Ministry of Health initiative to get space to pass on this communication. We also have to have livelihood interventions in the space before the crop grows. What does she do for livelihoods? And we also recognize how important social belonging is. And we know the interventions need to be woven into what she does in her normal day-to-day. Otherwise, it will be difficult for her to participate if it's going to distance her from her community. We also, sorry, I lost my notes for a bit there. Yeah, so then there's also the issue of the local government being involved. So for example, if someone in her family has alcohol or substance use problem, constantly being arrested and for misdemeanors, or it really interferes with the recovery process. So even the local government to understand that addiction is a real problem, is a health issue, and you don't legislate it, you help people to recover from it. Next slide, please. So for us as a community mental health organization, we see a lot of opportunities in research. We hope that we would see more researchers who identify what we as implementers, what people with lived experience, and what the community and the leaders want to understand better and to formulate research accordingly. I really like to hear Dr. Mona Whisk had mentioned this, that not to do research that addresses the knowledge gaps that we have. And also we hope for research that we can communicate back findings in ways that they resonate and that are easy for our communities to understand, especially to show the impact of mental health challenges in their own communities. Next slide, please. I think I'll end by inviting research partnerships. We do a lot of implementation on ground. We do not have the resources to do the research, and we welcome partnerships. Thank you.
Thank you so much, Rosemary, for painting a picture of how systems thinking has been used to address community needs in Kenya. My question for you is, in an ideal world, what data would you have to support your systems approach? And why is data hard to collect?
Thank you, Sireesha. So I'd say in an ideal world, we would really want to have data on the social return on investment for mental health. A lot of times people want to see a direct correlation, like we see eye health intervention. I put in this much money, so many people got cataract treatment, and they can therefore see. The journey to mental well-being is not as linear. There are many social determinants, many gaps along the way. But it would be so good to be able to demonstrate in a community that because you facilitated this, this community to have these kinds of interventions, this is a social return, or even the economic, if it's possible to quantify financially what the return on investment is. Another thing is, to see more research on what is working within the community, because we have a community where people face the same challenges and have similar resources, but some thrive and have good mental health. What is this that is working for them, and how do you make it work for the rest of the community?
Thanks, Rosemary. And I think the second part of that question is, why is data hard to collect?
Yeah, sorry, I forgot to answer that one. So, Sireesha, one of the biggest challenges, we simply, as a small community-based organization, we do not have the capacity to do research. Or maybe we just do not know how. So it would be so good to have researchers, that kind of expertise, to help us develop the tools, to help us analyze. We collect a lot of data. So anecdotally, I could tell you what was Amina's situation before and what her situation is now. But collect that data and analyze it and present it as evidence is a challenge for us.
Thanks so much, Rosemary. That really enlightens, sort of my perspective on how difficult it is to work within these community settings. I'd like to move on to our final presentation. I'd like to invite Dr. Bibi Oladeji, who will be speaking about investing in leadership, learnings from the Mental Health Leadership and Advocacy Program. Please go ahead, Bibi.
Thank you so much, Sireesha, for that kind introduction. And let me appreciate the organizers for having me on this, because investing in leadership is important for building mental health systems and improving access to mental health care. So I will be speaking to our experience and the lessons we have learned from running the Mental Health Leadership and Advocacy Program, which is a capacity program and leadership advocacy program for mental health at the WHO Collaborating Center in Ibadan. So I will give a background to what led to the development of this program, and also speak to the program and then focus mainly on speaking about the leadership course. Next slide, please. Yeah, the program was developed in an attempt to tackle some of these barriers to developing mental health systems that was highlighted in this Lancet series published in 2007. And the key barriers that were identified in this survey of international experts in mental health included the fact that mental health leaders really did not have public health skills for them to be able to have a systems thinking or public health approach to tackling mental health problems. Many low and middle income countries have very few numbers and types of professionals working in mental health, and this results largely in little resources available for mental health, and most of the resources available being concentrated in urban areas. So there's inequitable distribution of mental health care, and funding for mental health in many low and middle income countries is largely not a priority for the leaders. So there's a need to generate political will to improve that. Next slide, please. So what are some of the solutions in to some of these barriers? So one key solution is to improve the public mental health knowledge among specialists and other key stakeholders in mental health, for them to have specific capacity to conduct evidence-informed advocacy and generate political will to improve funding, to improve attention for mental health, and to build their capacity to take leadership roles in mental health service development. And I guess one of these quotes from that publication actually captures it well. The leadership cannot be expected from clinicians turned by default into administrators and planners. Their views, experience, and training are not compatible with population-oriented mental health actions. Simply stated, that it's difficult for people that are not well trained in public mental health to have a systems thinking or systems view to developing mental health systems. Next slide, please. So this led to the development of this program in 2010. And this program was funded for the first 5 years by the Australian Aid Agency. And in response to the success of the program, the program was funded for an additional 5 years from 2010 to 2019. And there were two components to this program, and the components were kind of to drive two key overlapping goals that the program had. One goal was to build capacity of mental health leadership, and this was done through the mental health leadership and advocacy training course, which I'm going to focus more on for the rest of the talk. And then also to develop stakeholder groups who have the ability to identify what were some country-specific mental health service needs, and then to work with the country, the policymakers, and to develop those service areas. And one of the stakeholders that we worked with, especially in Ghana, was the Basic Needs Ghana. From the last speaker is from Basic Needs Kenya. So the focus of attention for the program really was on these 5 Anglophone West African countries: the Gambia, Ghana, Liberia, Nigeria, and Sierra Leone. Next slide, please. So as I said, I'll focus more on talking about the mental health leadership and advocacy course. So this course is specifically designed to raise mental health leaders and to equip them with the skills that they need to be able to design and develop and implement mental health services, to promote the human rights of people with mental disorders, and deliver evidence-based advocacy to improve political attention to mental health. So this was the core goal of the mental health and advocacy training course. And please, next slide. So who does this course target? Targets leaders at various levels of the mental health system. And this includes mental health professionals, psychiatrists, clinical psychologists, social workers, nurses. We also recognize the fact that service users and their caregivers are also leaders in their own right for mental health. And we also needed to bring policymakers and politicians on board so that they can understand the need to improve funding and to improve goodwill towards mental health services. And the executives of humanitarian and non-governmental organizations are also leaders in mental health. They all have a stake. And head of relevant government agencies that deal with mental health, the Federal Ministry of Health, and opinion leaders of various types, people working generally in mental health, were the targets for this program. Next slide. So the curriculum, let me speak a little bit about the curriculum for the course. And because the curriculum was largely developed basically to meet those needs that were identified. So it was informed by current best evidence available in the field of public mental health and mental health service development. Even though over the years, the core areas of the curriculum are largely preserved, but the contents, of what the specific content of the lectures, however, have been dynamic over the years. And the curriculum was reviewed in 2012. That is about 2 years after running 2 years into running the program. We had a major curriculum review, another one in 2015, And we had another one this year in 2024. Next slide, please. So let me speak a little bit about the course content. So the course content, as I said, is basically tailored towards developing capacity in these main areas, helping leaders to understand the burden of mental health and mental, neurological, and substance use disorders, the determinants of mental health that can be targeted in improving the mental health of people, and also talk about mental health promotion and provision, communication and advocacy, speaking, leadership skills development, mental health policies, legislation, human rights, and how to strengthen mental health systems generally, and what resources are needed for mental health. The way the program is structured, there are interactive teaching sessions which are delivered by global experts in these fields that in these core content areas. But the key thing is that there's a lot of practical sessions which are handled during the group work. So each of the teaching sessions has a group session that the participants have to work together on. And these groups are kind of purposely put together to have different people from different backgrounds contribute to developing the group work. In addition to the general group work that comes at the end of every session, we also have a group project which is given to the participants at the start of the course. And the group project is supposed to enable them to develop system thinking around to how can we develop a particular program, develop maybe an advocacy or develop a mental health system for a particular community. And they have time that they work on that group project all through the course, and they bring in everything that they learn in all the key content areas. And on the last day of the program, each group presents their group project, and then they get feedback from other groups and also from the experts that are facilitators in the program. Next slide, please. So even though I say, just to give some of the what we got from our follow-up survey. So we had participants, 271 participants over the first 10 years of the program. Usually the average is with like 25 to 30 participants on each course in every year. And we had participants across 11 countries in Africa, even though, as I said, it was initially targeted at 5 countries in Africa. But in 2024, through the Africa CDC Mental Health Leadership Program, we had 52 participants sponsored across 20 countries in Africa. And this map shows all the countries that we have had participants come to access the leadership training course from across Africa. Next slide. So as I said, we conducted a survey to review the first 9 years of the program, and the survey questions we sent by email to previous attendees on the program, those who accessed the course between 2010 and 2018. Unfortunately, we had like 45% of them respond to the call, and 99.1% of them mentioned how the leadership program had impacted their career and how it had improved their work performance. Next slide. We also surveyed their involvement with different activities following the program, and we can see that all of them, or the orange bars, are the proportion that are responding yes now to having taken part in all these activities following their attendance at the course. And we can see that all the various taking leadership roles at conducting advocacy research increased. Next slide. Other activities that we surveyed include how much they have engaged with policymakers. Before they came for the training, only about 34% had ever had any engagement with policymakers, but after the training, more than 62% of them had access to activities involving engagement with policymakers. Next slide. So the lessons that we have learned, I guess the participatory group design was very important in helping knowledge acquisition. And the fact that this course is focused on skills and competencies that are typically not part of traditional course curricula has made it to be impactful. A key limitation is funding and sustainability. Though the program is cost efficient, it requires $1,500 to $2,100 US dollars to train one participant. And we know that this, if participants are going to pay out of pocket, this can be a huge limitation for them to attend. Over the years, we've had scholarships provided by the funders, which has made the course accessible to many more people. And interest in the course is evidenced by the fact that we got funding for an additional 5 years. Africa CDC is also taking it up now. This year, there were more than 750 applications for the few slots the Africa CDC was able to fund. So there's a lot of interest for the program. Next slide, please. So just to provide this quote from one of the participants, that this training was powerful and encouraging, boosted my morale in tackling mental health issues, and it has built my capacity to advocate in a proper way. And it's also taught me to think out of the box. Last slide. So in conclusion, to improve translation of evidence to practice, we need mental health leaders across the various categories, researchers, clinicians, service users, and policymakers to acquire new knowledge and skills. And they also need to be able to develop and strengthen effective collaborations, which is what will be required. So the next step for us, we're working now with Africa CDC under their mental leadership program, and our colleagues at Cairo who also have a similar short course, to develop similar courses across Francophone West Africa and East and South Africa. So just to acknowledge my funders and my colleagues at the WHO Collaborating Center under the leadership of Professor Ogureji, who has been quite a visionary leader in this regard. Thank you so much for listening. Thank you.
For sharing how training has been used as a specific entry point into the system. Now, your course supports people to gain new knowledge and learn new skills. And more than that, it encourages the use of this knowledge and skills throughout their careers. My question for you is, what is it about your approach that supports this, and how might other programs learn from you?
Okay, I guess one of the key things in our approach that has been helpful is that our curriculum was specifically built to meet a specific need. We wanted to improve leadership skills, so the program is kind of strong on training people on leadership skills. And we also wanted to improve political will through advocacy. So we have a strong communication and advocacy component on this program, which are things that generally are not taught in general core programs. And also we also take a public health approach to looking at disorders. Rather than focus on specific disorders, we look at the burden of mental health problems and how this can be tackled. So another thing is that the course is quite participatory. So all through the program, the learning process is quite participatory. So there's opportunity for both vertical and horizontal learning all through the program. And every group is always composed of people from across all the different backgrounds. So there's a lot of learning taking place from, having service users interact with the with professionals, people working in NGOs and working in different community aspects of mental health. So, and working with the researchers. So it's quite, all that has been part of the thing. Another thing that we have done to make this a little more, quite more sustainable, largely more sustainable, is to build local capacity through knowledge transfer. So when the course started, we had a lot of international faculty, which now we have few international faculty and more of the local faculty actually taking more of the courses. So those are some of the things that we have learned that has strengthened the program.
So much, Bibi, for your insight and your presentation.
Thank you, Sireesha.
I also would like to thank all of our speakers for their informative and thought-provoking presentations. As you may have noticed, we actually started off with big systems thinking with Jeffrey and Dan's presentations, and we followed up with presentations involving illustrative examples that speak to specific parts of the system. Deb's talk about the learning health system, Rosemary's presentation on meeting community needs in Kenya, and finally, Bibi's presentation on investing in leadership. So at this point, I'd like to welcome back all of our speakers for our audience question and answer and panel discussion portion. If you don't mind turning on your cameras, that would be great. Okay, so there are quite a few questions that have come through, but one question in particular has come to the forefront. One thing, and I'd like to ask Dan to start off answering this question, and then we can go to the other speakers. Dan, one thing that we haven't talked about too much is the impact of organizational culture. Perhaps we could start with some of your reflections on this and what, from your experience, supports the development of a culture that facilitates systems thinking.
Well, that's an interesting one to start with. You know, a long time ago, I studied anthropology. So, of course, I'm very interested in the socio-cultural perspective. And I think one of the most interesting aspects is this sort of distinction made between the so-called emic and the etic, by which I mean the approach to understanding a situation from either a kind of insider, sort of subjective perspective, or from the kind of outsider or kind of objective perspective. So those two approaches across many of the social sciences, you know, lead to very different kinds of research questions. And I think we'd all agree that you need certainly a very culture-informed kind of approach. So a very emic approach to health systems research, because culture in its broadest sense, whether it's organizational culture or the norms and values of a society, you know, these have a deep influence on all aspects of the social system, of which maybe a health system is just one part. So shaping people's, for example, beliefs about mental health, shaping behaviors like, most importantly perhaps, help seeking. If you have rife stigma, discrimination, households will not seek services for fear of being stigmatized. So it's vitally important when we're talking about being able to understand, you know, the context of a country or a health system, of a research question, policy question. You have to bring in that cultural perspective. But you know, and there is another, even the culture of evaluation. You know, some countries are more into it than others. Or some parts of the world are more into it than others. Certainly what we see. So I think, you know, you've seen examples like we just heard from you know, about the leadership program in Africa. That's I think a fantastic way to build up awareness, understanding, as well as, you know, the skills and competencies around leadership, to take that kind of nuanced, culturally informed approach to tackling some of the health system bottlenecks and barriers that all countries face. Over.
Thanks so much, Dan. There's a lot in that answer that you provided in terms of thinking about things from an insider-outsider perspective, but also really understanding the organizational culture and some of the maybe larger norms that might be present, even in regards to thinking about mental health in general, you know, the stigma that's associated with that. And perhaps because you spoke about the talk that Bibi shared in terms of integrating certain thoughts and ideas within the leadership program. Perhaps, Bibi, you can take on this question as well. What, from your experience, supports development of a culture that facilitates systems thinking?
Yeah, I guess one of the key things that will be important in facilitating systems thinking is for people to have, you know, a more nuanced understanding of what actually systems thinking is. And these are things that you actually require training for you to be able to identify, you know, all the different moving parts, and for you to know how you fit into that system. So I think that's one of the key things that is very important, building the skills required amongst different people that, you know, are needed to improve that system. For example, in a lot of developed countries now, and part of the things that you shared earlier is the fact that you need to have service users and their voice to be strong. And that also came out from the presentation earlier on the youth program from Australia. So it's important that you have from Canada, sorry, people have to know what their role is and how they can play a part in improving the systems. And that's one of the key things that capacity building can do. So taking that structured approach, there's a need to build capacity for all the various stakeholders for them to know what they need to do and how they fit into that culture. Thank you.
Phoebe. Deb or Rosemary, any thoughts on this question as well?
Not from me.
Okay. Thank you, Rosemary. Deb, go ahead.
Just trying to unmute. I would probably just comment on having a learning-oriented culture where there's leadership commitment that prioritizes learning. You know, we talk a lot about within organizations ensuring that staff and young people and families who are working in that organization feel safe to share their ideas so that you can ensure that learning from mistakes and continuous improvement and seeing those as opportunities can really be embraced without having any fear of reprisal, for example. And also like recognition of learning. Like we tend to think that incentives are just for like research purposes, or, you know, people are motivated to do incentives for certain things, but reward systems really actually work. And it's important to reward knowledge sharing or collaboration in that learning culture so that we can continuously ensure that that is really prioritized, because I think that's the only way we're really going to have continuous improvement is if we embrace it and we reward it for people who value that experimentation or, you know, making mistakes and learning from them.
Thanks so much, Deb. So from what I heard from you, BB, is really defining what systems thinking is and how individuals or organizations fit into the system. And then also from you, Deb, understanding that it's important to generate a learning-oriented culture within organizational settings as well, and involving some sort of reward system as well. So I'd like to move on to the next question, and this somewhat links to training as well. I'd like to hear the speakers, all of your thoughts on if and how to foster a systems thinking approach and culture through how we train the new generation of professionals. And perhaps BB, you can get us started, and others can join in.
Well, just to say that learning culture is kind of evolving and changing, and this new generation are more with social media and so many of these technologies, AI and all that. So in training this new generation of professionals, that's one core skill that I think most of us, especially from those of us in the older generation, would need to learn how to use more of some of these new tools that are, you know, which is what the newer generation kind of they kind of relate well with. So we need to factor that in. And then the fact that the culture of learning has changed. So we also need to find a way of evolving that learning culture and, you know, blending that into the training of new generation. The older generation were more with physical books. Now the newer generation tend to use more of the gadgets and stuff. So some of those things have to be factored in training this new generation, and the way that the learning environment and the learning systems has to keep upgrading to, you know, to be able to benefit everyone. Thank you.
Anything to add to that, given that you're speaking about health learning systems and all of the individuals that are actually involved in health learning systems, one of which are professionals?
I might just add, oh, sorry, was that me or is that Daniel?
Go ahead, Deb.
I didn't know if you asked for me or Daniel, so okay. I would probably just quickly add that similar to what we've heard is that investing in the learning infrastructure is going to be really important for our new professionals. So somebody told me the other day, like, if you don't learn AI, you're going to be left behind because everybody's using AI. So ensuring that, your tools, learning management systems are necessary, data analytic platforms that really resonate with our new, young entrepreneurs, AI-driven insights. Simulation and experimentation is huge, where teams can actually test new ideas and actually do it in an environment where it's encouraged. And having that regular training program to constantly upskill or at least build that capacity within your organization on how we best learn.
Thank you so much, Deb. And sorry, I should enunciate a bit better. Dan, did you have anything to add to that?
Well, I was talking about this Emerald project, and something perhaps I didn't emphasize enough was that, this was a funded research project, but it was a key objective, and part was the kind of building of the capacity. And by that, we don't just mean researchers, but the local decision makers. So in each of the countries, we had a close, not just the occasional check-in or dialogue, but they were real active partners in the program of work. Okay, I always don't want to call it research because that might make them sort of steer clear. So I think the learning, is that that works both ways. I mean, it's doubly beneficial, for each of both the researcher side and the local decision makers. And I think it helped to build up each other's, each group's understanding of the issues and the perspectives, and in so doing, you are building up that better kind of system thinking approach, and seeing the real policy issues, but also why, what if you like, the research side can really bring and help to address and resolve, which are the real policy questions that are often facing the local decision makers.
So much, Dan. I'd like to shift a little bit to thinking, Rosemary, did you have something to add to that? Because this next question was directed towards you, but if you do have something to add, please go ahead.
I wanted to mention the need for training, step training for different cadres of people who intervene in mental health. So there's the professionals, but like in our setting, we have a lot of care delivered by community health promoters or lay volunteer counselors, and there's need to make sure that their training is fit for purpose, that they do gain the skills that they need to serve their communities. Thank you.
Thank you, Rosemary. So I think building off of, thinking outside of, just the health system. I know we're talking about professionals, not only within the health system, but outside as well, decision makers. A theme that came up in your presentation, Rosemary, is that systems thinking means the whole system. And it's not just the health system. So what are the most important touch points that you see for improving mental health research implementation? And perhaps let's just start with that question. The important touch points you see for improving mental health research implementation.
Yeah, so Sireesha, I would say one of the important ones is to work with the organizations that inform government policy. So, for example, in Kenya, we have the Kenya Institute of Policy Research, KIPRA, and the government listens to whatever papers they produce. So we have universities that will have excellent research, but those tend to be academic research. They go into papers, they're discussed in conferences. But when a minister of health wants to know what is it about this issue, they'll tend to go to what data there's a Kenya Bureau of Statistics and KIPRA. That's who they'll go to. So to have more collaborations with the institutes that generate evidence for government. And then secondly, I think is to understand how do our leaders learn? And unfortunately, our leaders also listen a lot to what is in the media. So if we are not sharing this information with the media, and the media picks up, if the media are carrying on the stereotypes and the myths and misconceptions that are there, unfortunately, our leaders are listening to that as well. So how we disseminate our research is really important. Thank you.
Thank you so much, Rosemary. Those are really important aspects to consider in terms of how people, especially decision makers, are receiving the information. Are there any other important touch points, Dan, Deb, or BB, that you see for improving mental health research implementation?
Well, shall I go? Oh, I'm happy to wait. But I mean, one thing I
Please
was
go
going to
ahead.
say. Okay, thank you. Was around the the outcomes of interest. I think the part of the conversation has to be around what it is that system researchers are interested in, as opposed to clinical researchers or services researchers. And I think the outcomes are distinguishable. Clinical researchers want to know about outcomes like, symptoms, functioning, quality of life, etc., right? Service researchers want to know about how effective the service is or the intervention is, how fair or equitable, or it could be cost. I'm a health economist, so looking at cost effectiveness, of different service models or interventions. But implementation researchers have a different set of real kind of vital outcomes of interest, which I think sometimes are not clearly articulated or appreciated. Which is much more around things like the acceptability of a service or an intervention to a local community, or how sustainable or feasible is what being done to the in the local culture, like we're saying, or what's the degree of fidelity if you're doing scaling up psychological interventions. How faithful is it to the so these are slightly different questions, I feel. So I think the more there is clarity about what are some of those key outcomes of interest, I think that can help.
That's really helpful to try to socialize what implementation researchers are actually interested in and thinking about, and socialize that with others who are working within the system as well, and so that they understand why implementation research is important from a certain lens. So thanks, Dan, for that information. To shift a little bit to talking about culture, and Deb, this question is for you. I'd like you to reflect on how meaningful engagement with the community and service users can contribute to building culture.
Well, I think we heard it across multiple presentations around co-design or community-based participatory research, and how important it is to include all of the relevant partners that you may have as part of the work that you're doing to prioritize the implementation research that addresses the inequities. I think we heard equitable services, but it's also ensuring that outcomes are equitable, and that there's equity in outcomes. And so I would say that engaging your stakeholders, your partners in all parts of the work that you're doing is really what's going to produce the most meaningful results for them. Having them contribute to the research questions, the data collection. We use concept mapping, which is, when you collect qualitative data, and then you have an opportunity for your participants to then rank your themes and to, discuss whether those themes are relevant or not. And they actually drive what the findings say. So there are lots of approaches out there. They may take more time, but they are absolutely necessary to really be able to reflect all of the diversity that exists.
Thank you, Deb. Rosemary, I'd like to ask you the same question as well. Can you reflect on meaningful engagement with the community and service users and how this can contribute to building a culture supportive of implementation research and systems thinking?
Yes, I'd like to mention how important it is to include, to meaningfully include people with lived experience in the community. And we actually had a conversation around this recently with the AP, one of the research institutions conducting mental health research in Kenya. And people with lived experience had a chance to express themselves and say how it can be very difficult to be engaged at the tail end, and like it's sort of tokenistic. So it needs to be meaningful engagement from the design perspective. And I like that we already had the conversation how important it is to know what do they want to understand. So not only what the researcher wants to get out of the research, what do our communities want to understand? There are certain beliefs they hold dear about mental health, and they probably have a basis for them. But to understand deeper, why is it so, if indeed those are myths and misconceptions? So to really have an opportunity for this to be demonstrated to them that it indeed isn't a scientific truth. So I think it's important for them to be involved throughout, even when designing the questionnaire. So sometimes it's difficult. We've had project participants say how difficult it is to sit through answering a 20-30 question questionnaire, and some of the questions seem similar and they don't understand why. So even to understand how the tools are developed, why some questions may be similar, to really ensure that they understand, so they're not just a participant in the study, but they've really been involved in the development of the same.
Thanks so much, Rosemary. So from what I heard, Deb and Rosemary, does that meaningful engagement of a variety of individuals who are actually involved in perhaps service use or programming from the get-go, so from the beginning, and making sure that the questions that they have are also answered throughout the process as well. So very, very important points for us to consider. I'd like to shift a little bit now to thinking about evaluation. Dan, what are best practices for evaluating bottom-up intervention within a mental health system, to your knowledge? And I'm thinking especially for interventions that have existed within the system for years. What are appropriate study designs for evaluating implementation and effectiveness? And I know you touched upon some of this within your presentation, perhaps, but would love to hear your thoughts on this.
Well, I don't know if I'm the best of the speakers, but I mean, we were talking about the emic and ethic, and but regardless, I mean, the start has to be the understanding the context, what we call a situational analysis. That is let's say a prerequisite to approach, undertaking appropriate health systems and implementation research for sure. And part of that is, as we've just also been saying, that means assessing different people or different stakeholders' perspectives and positions on issues, which might be very competing. A topic that is well known in our field is around the deinstitutionalization, and this is a good example of, if you want to do a health systems research project on deinstitutionalization, you'd start with that kind of situation analysis, and you would encounter very different sets of views, right? Depending whether you talk to residents of psychiatric hospitals or directors of them, or local community, local policymakers, the general public. It's really very, very different. So somehow that needs to influence the design and the scope of the health systems research project, right? Because you need to somehow address those different and maybe all equally valid perspectives on an issue. So that's where the complexity kind of comes in, and then you have to come up with appropriate mixed methods designs and to address some of those different kind of health system questions that come from that initial situation. So I think that would be my starting point, but others may have more technically correct ways of saying this.
Deb, do you have any thoughts about evaluating a bottom-up intervention within a mental health system?
Well, I mean, I think Dan, touched on a lot of those pieces. I think it's important for us to really understand the difference between evaluation and research, and I think that's not always well understood. And so the evaluation is time limited, and it really needs to feed back into being relevant at a policy level to the stakeholders, whereas research, it can be ongoing. And you're really trying to generalize more broadly across a population. So like, despite that's like, evaluation 101, people still sometimes struggle with understanding, well, what does that mean for an evaluation of an intervention? That means that we might do, a hybrid trial where you're simultaneously looking at the effectiveness of the intervention as well as the implementation strategy, so you can easily convert some of that into practice. Or you want to use data that's already collected within your organization in your EMR, like your electronic health record, so that you're not, introducing, more mechanisms to delay the evidence getting into practice, which I think research can delay, as we've seen, but evaluation can speed up that process. And it can still be very rigorous. I think the idea that mixed methods or qualitative is not a rigorous approach. I hope we're beyond that now. And I think there's a lot of implementation scientists out there who have expertise and have studied this for a very long time, who we should be hiring within our organizations if we have the resources. I know we don't have the resources to lead some of this work.
Thanks so much, Deb, and also for providing that clarification between evaluation versus research and how they're both different and can be used for different purposes. So we are coming to very close to the end of our Q&A session. So I'd like to ask a closing question to everyone. The question is, from your perspective, what's one thing that you'd like to see happen or one thing you'd like to stop to support and strengthen the mental health research and implementation system? Rosemary, I'd like to get started with you.
One thing I would like is a lot more collaboration between us implementers and the researchers. They have so much expertise that we do not have the resources to have within our organization. And really, it's likely not necessary because there's already expertise that exists. So if we could collaborate more, there would be a lot more evidence generated. And this could help also people who participate in the research understand why, if I participated in a research today and my situation hasn't changed, but what does how is that helpful, my having participated, and how do we inform also our leadership on what the good things that are happening on the ground that could be scaled up? Thank you.
Thank you, Rosemary. Deb, same question to you. What's one thing that you'd like to see happen or one thing that you'd like to stop to support and strengthen mental health research and implementation systems?
I think what I'd like to see continuing and even more, if we can, is addressing disparities, focusing on equity, inclusion, thinking about diverse populations, how we can reduce the disparities in mental health, and investing, in our services for those that are most at need, most marginalized, and including the community as part of that. So that's what I want to see us continue to do and stop doing. I think we need to stop being fragmented or siloed or territorial. And events like this really help to share all of our knowledge and experience, and more of these kind of things are really important, so we don't, feel threatened by each other's work or funding, or we're really here to just learn and share and give your time up as much as possible to do that.
Thank you, Deb. Dan, over to you for your thoughts.
Thank you. So we talked a bit about the methods and design and measures, also a bit about outcomes, but I want to come back to the beginning, which is like, what are the questions that we need to so my suggestion is that we develop a kind of inventory, an open listing of relevant health system research questions in the area of mental health, grouped by topic, theme, group, whichever level. But let's start agreeing on what are some of the critical questions that can and could be addressed through application of a health system lens, right? I think that's a practical suggestion also for the follow-up, the Lancet Commission, the International Alliance, that this could help to, for example, form the basis on a call for applications, in a particular area. So yeah, that's my suggestion. Thank you
So much, Dan. And finally, last but not least, Bibi, what's one thing you'd like to see happen, or one thing that you'd like to stop?
Okay. Thank you. One thing that I would like to see happen is building more capacity building programs into all our research and program efforts, so that we can have, skills that are specifically tailored to different categories of stakeholders in mental health service systems, like what Rosemary mentioned about service user not having that capacity to know how to get involved in research. So building their capacity, having training programs that are specifically tailored to help them identify what their role is and how they can contribute to research, and having researchers also policymakers capacity built into how to identify correct evidence and how to make use of those evidence. I would like to see more of that, so that everybody can collaborate together more, work more effectively in generating advocacy for mental health, increasing the political will, and co-creating evidence when everybody knows what they need to do in the context of creating that evidence. That's one thing I like to see. And to add my voice to Deb, that we need to stop working in our silos and let us all come together to have a unified voice for mental health. Thank you.
So what I heard is more collaboration, addressing disparity, investing in services, developing an inventory of research questions that relate to thinking about service systems in general. Also developing capacity building programs, really understanding the needs of different professionals and how they work within different sectors as well, and developing their capacities to work with a systems lens. So I think all of those suggestions in terms of what we'd like to see happen are really important, and definitely things that we'd like to look forward to as we move towards using a systems approach within not only our own work, but trying to disseminate that thought to others that are working or trying to work within using a systems perspective. So I'd like to thank all of our presenters for the lively discussion and all of your contributions to answering some of the questions that have come up in the chat. So we're now going to take a 5-minute break ahead of our discussion with the Lancet Psychiatry co-commissioners, Matt and Beth. So I'll see all of you back here in 5 minutes. Thank you so much. So I'd like to welcome everyone back from break. I'm now very excited to hear from our Lancet Psychiatry co-commissioners, Dr. Matthew Eisenberg and Dr. Beth McGinty. We've heard a lot about systems thinking today and some of the successes and challenges when applying systems thinking to mental health. I don't see Matt or Beth yet, so I'll wait to pose that.
We're both here.
Okay,
I'm
great. Okay, awesome. Okay, so my first question is for you, Matt. What gets in the way of systems thinking in mental health?
Thanks, Sireesha, and thanks so much to all of the speakers today and putting this together. This has been such an amazing experience to hear everyone's thoughts and experiences on these important issues. So I just wanted to say thank you, and I enjoyed that so much. What gets in the way of systems thinking in mental health? A lot of things, and I think we heard about a lot of them today. I think one of the things that's necessary for systems thinking is this meaningful engagement with stakeholders, which was talked about in the last session, and not just engagement at certain cut points, but engagement throughout the process with these stakeholders, folks with lived experience. And it's really hard and it's really expensive to have that meaningful engagement throughout the process, and it makes it hard. I think another thing that stands in the way that we talk about in the commission report is the fragmented research approaches. I think this linear model that was referred to today, it's not really aligned with the complexities of the real world, and the implementation considerations are often treated as an afterthought. Two more things on my mind. One would be, and this was talked about today too, I wrote some notes about it, the limited focus on contextual factors. I think is when we think about systems, we need to think about not just the health system as well, especially for those with mental health conditions have such diverse and heterogeneous needs across social services and housing and support, and not just their clinical care. So I think if there's research is focused solely on the health system and solely on the clinical intervention, it's harder to see that bigger picture where there might be chance for intervening and there might be chance for these touch points. And last, one thing that we came back to a lot today is the need for more collaboration. There's disciplinary silos in research, and it's hard to really bridge these gaps and really implement a systems way of thinking without representatives from all different types of fields and all different types of disciplines working together. So those were the initial thoughts I wrote down throughout this session so far.
Thanks so much, Matt. I think you've touched up on a lot of different points. And I think one thing that has come up, and I think we heard a question about, thinking about context, but also within low and middle income country context versus high income context. I think that plays into, thinking about health systems and how and what that means within those particular situations, and thinking broadly in terms of what other systems are included or what other sectors or aspects should be included when we're thinking about low and middle income settings. So that really resonates with me as well. Beth, the next question is for you. We had the pleasure of hearing from a diverse range of experiences and perspectives throughout the speaker presentations. What are some of the key themes regarding systems thinking that struck you across the various speakers?
Thanks, Sireesha, and I'll echo Matt's thanks to our incredible panelists here. I learned so much, and it's been really a joy to hear all of these shared perspectives and experiences and expertise from different parts of the world regarding systems thinking. So I've been madly scribbling notes throughout the whole thing about what key themes I'm picking up on here. And I think that I'll highlight two in my response to this question. question. One is networks. I think every single panelist talked about networks in some fashion. Deb, in the context of the Youth Wellness Hubs Ontario Learning Health System, talked about networks of networks, right? So it's sort of networks exponentiated in some cases. And I think networks are just central to systems thinking. And what struck me was the different flavors of networks that were exemplified by our different panelists. You know, within system networks of implementers, where a system is a defined, healthcare system with relatively constrained, although admittedly permeable boundaries, where you've got networks of providers and service users and administrators sort of working together within some defined boundaries, but also community networks and the networks of networks where you've got community networks interacting with a healthcare system, social service system, other kinds of networks. And so it just really struck me how important networks are when conceptualizing systems thinking, right? Understanding where we are in the network and how the rest of the network influences what we want to do, how important networks are in implementation itself. The networks are how things get done and how people interact with mental health services and interventions, and the importance of networks in policy and governance, which is my second key theme that I'll highlight. It really struck me that financing and government governance came up consistently across panelists. This is something that we also highlight as a key theme that sort of cross-cuts all of the recommendations in the commission, and one that, building off Matt's point, I think can be particularly hard to institutionalize within a learning health system type network, because policymakers operate often on different professional incentives and just in a very different context than implementers, service users, researchers. And so we heard today some examples of, collaborating with governance committees within government or within leadership groups of systems. And I think that really stuck out to me as the second key theme.
So much, Beth. I think your point about networks is really interesting, and the idea of really thinking about community networks. And I know thinking about like the formalized community networks that might be out there, but also the informal networks that just occur naturally within different contexts. I think that it's really important to think about how those different types of networks play into systems thinking. And then on your second point, the financing governance piece that seemed to be popping up quite a bit in terms of the different coming through the different speakers' presentations. It's interesting to think about the different incentives in terms of how policymakers might be involved or not involved, and perhaps some of their priorities, and just thinking about the term of, let's say, the term in office, and why it's important to think about perhaps like short-term goals, midterm, long-term goals, because sometimes those quick wins or outcomes are something that decision makers need to see when they're working within certain timeframes or certain confined spaces, and then how that leads into how they think about systems and whether they actually engage with some of the systems research or implementation research that is happening within their own contexts. And so, Beth, you also talked about how a lot of these some of the discussion topics that came up relate to the Lancet Commission recommendations. And that leads me to my next question, which is for Matt. Can you relate the Lancet Commission recommendations to what our speakers shared. So I know you touched upon some of those aspects already, but perhaps we can move into some of the recommendations that we haven't spoken about yet.
Yeah, thanks so much. And in the report, we have quite a few recommendations for the different levels, and thinking both recommendations for researchers as well as recommendations for those training researchers and those for funders. I think a lot of the recommendations were reflected in the speakers today, and there's a few that I think are worth highlighting. I think one is thinking about how to not just build these types of partnerships, but sustain them. I think this builds on what Beth was saying about networks and the need to systematize this type of partnerships. If you're going to have these successful co-creation models, there needs to be a very structured co-creation process, that includes all of the stakeholders and the governance arrangements and all of those things to really systematize it. And I think we saw these types of things in many of the talks today. I think Rosemary's, emphasis on community-driven approaches and Deb's on the leadership program kind of align with these need for these partnerships among researchers, implementers, communities, and to sustain them and really systematize them. Another thing that I think is worth highlighting here, calling out, is we do have these recommendations specifically for funders, and I think it's important to get into those, especially considering our wonderful host today. And I think one of them is the importance of funding portfolios of partnered transdisciplinary research that really brings together this pre-intervention, intervention, and implementation research projects. I think that if it can often be tricky to try to fund these large schemes of work, but it's also hard to really accomplish all of those goals throughout the I don't want to say the pipeline, because we're trying to transform the pipeline into a circle, but all of the pieces of that circle without kind of guaranteed funding and knowing that these different pieces are coming later. So I think longer timeframes and things that fund specifically this type of transdisciplinary work is important. We have many more recommendations in there. Those are the ones that I just wanted to highlight at this point.
Thanks so much, Matt. I definitely understand, some of the recommendations, but also, in your thoughts in regards to what funders can do. And I think that there is like some movement and some thoughts as to how to better support systems thinking. And so we are seeing movement within that funding sector to incorporate it more of a coordinated approach, not only within like specific funding portfolios, but also for networks of funders to work together to really understand how to move a systems approach forward. So it's an exciting time for that. And I think that we'll see a lot more of where that can go in the very near future. Beth, I'd like to follow up with another question for you. I'd like to understand from your perspective, where are the opportunities and what would be a practical way forward in terms of how to move systems thinking forward?
Yeah, absolutely. So you and Matt, with those last answers and discussion points, have, I think, unintentionally teed me up very well here, and that I'm perhaps going to reiterate some of your thinking. So I think that the opportunities here also relate to networks, to keep on my key theme. And in reflecting on learnings over the last couple of hours, I'm thinking about this based on the panelists' conversation in sort of two ways. One is we have great examples. We heard many of them today, and knowledge about how to build effective networks for learning health systems. But they're very implemented learning health systems, right? I work primarily in a United States context and engage with various different health systems across the US. And aside from the Veterans Health Administration system here, we really don't have learning health systems. It's something that we aspire to and that everybody talks about, but that it's very hard to implement in practice for a variety of reasons. I think that there are so many examples in other contexts. Again, we heard about many of them today, both high-income country and low and middle-income country, of what learning health systems look like. And there were some back and forth in the chat about this, sort of what does good governance structure look like? How do you institutionalize the feedback loops between researchers and implementers within these systems, like the nuts and bolts of how to do these things? I think there is really concrete opportunities in sharing that knowledge in a more practical, applied, like nitty-gritty way. My conversations with health system leaders are often like, oh, learning health system is like this big amorphous thing, but people don't understand the nuts and bolts. And like, frankly, I don't understand all of the nuts and bolts. And so I think that there are real opportunities for us to learn from successful systems across different contexts there. I think there's often a misperception that learning health systems are something that can only be done in very highly resourced, sort of fully integrated settings. And that is not true. We heard today that one of the beauties of learning health systems is that they are sort of built around local context, and that is sort of the underpinning there. So I think there are real concrete opportunities for our community writ large in mental health implementation research to learn from each other on the nuts and bolts of learning health systems. And then the other piece, which we really emphasize in the commission report is, and again, I think came up as a key theme today, is even more broadly than that learning health system point I just made, sort of building our network of expertise around global mental health implementation research. We tend to be siloed. It's, I think, often a misconception that high-income country contexts and low and middle-income country contexts can't learn from each other, or that it should all be unidirectional and the high-income countries know everything, which is, of course, nonsense. I think the low and middle-income countries are actually way ahead of many high-income country contexts on systems thinking, and that a lot of the great mental health systems research has come out of those contexts. But we don't, at this point, have great avenues for sharing our expertise with one another. This webinar this morning is a example of what that might look like, but I think that there are very concrete opportunities to sort of build this global network through doing a better job, de-siloing our conferences in terms of making sure both researchers and implementers across contexts are participating. The funding networks that you talked about, sort of bringing together networks of funders, again, with sort of expertise across contexts is another example.
Thanks so much, Beth. I really like that idea of building networks across global mental health implementation research, but connecting everyone. And something that's really important, and I think you're right on the mark, is that there's a lot of great research that's happening in the global South and within those contexts. And what is the best way to share that? And even having more of the South-South collaboration as opposed to always thinking about North-South information flows. And I think that definitely that's something that we can look forward to in terms of strengthening those networks so that we are seeing more of this global South knowledge being presented in a way so that we can all learn, and not only within research communities, but also within the implementation and implementer communities as well. So another question, only two more to go, but I'd like to shift back to you, Matt. I was thinking about hearing about your perspective in terms of how we can apply all of these learnings that we've heard about today to the pressing youth mental health crisis.
Yeah, thanks so much. And I'm conscious of the time, so I'm going to keep the answer short so we can get to the next question for Beth as well. I think one thing pops up to me when I think about it is that a lot of the approaches we talked about are important in when we think more globally or more at a macro level about the mental health crisis, and they can also be applied at the more micro level. So if we're thinking about, specifically the youth mental health crisis, I think it's a lot of the same type of principles that we talked about. And there's one that I'm going to use this opportunity to highlight just because we didn't have a chance to talk about it much today, but I think it's important and it was a key theme in the commission report. I think we talked about the importance of prioritizing bottom-up approaches, and we believe in that and so strongly, and the need to engage youth and their families directly in the design and evaluation of interventions. And we talked about that, right, to make sure that they're contextually relevant and scalable. I think one thing we didn't talk about is that there's a world of evaluation outside of RCTs. I think when we talked about methods, we talked rightly about RCTs and qualitative research. But one of the chapters in the commission report is all about non-experimental methods for causal inference and the need to use this more in implementation research. We talk about the various methods in the report, so I won't get into them, but I can say that they can be particularly useful for some of these systems level questions when randomization is neither feasible nor ethical. That's when these types of methods can really help a lot. And the second way they can help is with the generalizability. I think sometimes in the pursuit of an RCT, we really narrow our population of focus. And I think that some of these non-experimental methods can use a wider population and can give that focus on external validity that we need as well. So that wasn't 100% an answer to your question, but I weaved it in because I think it was an important point that I wanted to make at some point.
Definitely an important aspect that we didn't really touch upon too much, but it's really interesting to hear how your perspective is on these non-experimental methods and how that actually increases the generalizability of maybe some of the results that come out through that methodology versus, the gold standard RCT methodology. So I think that you did answer the question, but in a different way. So with that, I'd like to move on to the final question, which is for Beth. When we design implementation efforts, how can we incorporate a systems approach? And how can decision makers support incorporation of this approach from the beginning?
Thank you. I love this question. And again, I'm going to, I think, hopefully echo a key theme that we've heard throughout, which is co-creation and this idea that really central to understanding systems and therefore to designing implementation efforts within systems is we need to have all of the relevant perspectives at the table. We need service users, we need the implementers, be they clinicians or community health workers or the range of other potential implementers out there. We need policymakers, we need other kinds of decision makers like systems leaders. Who exactly the relevant group is going to depend on context, but When designing implementation efforts with a systems approach, like the first step is sort of understanding the various perspectives and pieces of the system. So co-creation is really central to that. There are various models for co-creation, and I'm using the term co-creation. There are sort of different flavors of co-design and similar approaches. So I'm using that term in kind of a big tent way. But at this point, we have good evidence and good examples of how to use these kinds of approaches. And so I think that the co-creation approaches really need to become the norm in designing implementation, and decision makers can support that in a range of ways, by making it the expectation for implementation within various systems, however they're defined, communities, health systems, et cetera. Funders, I think, have a role to play here by, potentially requiring, but also resourcing the co-creation approach, which, as we've heard from various folks, is critical, but also hard to do. It takes time. It involves relationship building. It's messy. People have different priorities and perspectives. And this approach just really historically hasn't jived with how we fund a lot of our mental health implementation and research efforts, which are envisioned as sort of very linear and fairly discrete. So I think that big picture, centering and incentivizing co-creation is key.
But it's a really important point, and thinking about how co-creation is typically done or not done. There are ways to integrate or to require or to facilitate co-creation to be a part of implementation science research. And from a funding perspective, there are ways to meaningfully involve, let's say, those that are thought to be beneficiaries. They can also be part of the process. And as I mentioned at the beginning, our Being initiative meaningfully requires that meaningful involvement of youth is part and parcel of some of these projects or innovations that are being proposed. And so I think there are ways forward. So I really like that we're ending on that positive note of really thinking about how we can better use the process of co-creation as part of implementation science research. So with that final question, our session comes to a close. A poll is about to pop up in your chat, so I'd like to encourage all of you to complete that and complete the evaluation form. I'd like to thank all of the speakers and the panelists for sharing their experiences and perspectives about systems thinking related to narrowing the mental health implementation gap. I'd also like to thank all of you in the audience for attending and for sharing your thoughts in the chat and for providing us with very insightful questions for our speakers. Now, before we end, I'd like to note that IAM HFR has just opened registration for the next event in this series, which will be taking place on February 6th and is entitled, "What Do We Mean by Evidence?" A link has been posted or will be posted in the chat for those who are interested and want to learn more. So finally, again, please take a minute to complete the evaluation form, as we'd love to hear your feedback about this session. And once again, I'd like to thank all the speakers, the panelists, and the organizers at IAM HFR, as well as audience members for making our first session within the series a success. Take good care and bye for now.